heart damage, or we're looking at lab values, someone's coming in short of breath, whatever, we're looking at the first one that we look at, or the one that we really look at for MIs or heart attacks is troponin. Because troponin will be released when there's only heart damage. So our levels are 0, but when you have heart damage, it will raise, and then it goes back down to 0. So that's why we look at it after like every 3 hours, because we want to see that trend to see if this person is truly having a heart attack. If you have like CHF, some people have chronically high troponins because they have CHF, their heart is damaged. It's already throwing out the troponin. So you only have troponin when there's heart damage. The other one is myoglobin. This is detected 1 to 3 hours after injury, but it's not cardiac specific. So this could be skeletal muscle. So it's not specific enough to the cardiac that we want to focus on that one. The only one that is cardiac specific is the CKMB. That is just heart tissue, myocardial tissue. CKMM is skeletal muscle. CKBB is our brain and nervous system. So when there's damage to any of those tissues, they will be elevated. But the problem is that the CKMB is detected like 3 to 6 hours after the injury. So it comes after the troponin, and I used to have a graph, but I don't have it anymore. But what happens is we'll recognize troponin first before CKMB. So that's why we look at troponins for someone that's having a heart attack. But you'll need to know the different CKs and troponin. The other thing that you will need to know are our lipids, and you already know these because you took a quiz on it last week. Do I have them all? No. So our total cholesterol is below 200. So these people, this person, if they have cholesterol above 200, is at risk for cardiovascular disease. Triglycerides we want them under 150. Our HDLs, we want them above 40, and our LDLs, we want below 100. Unless they're already at high risk, then we want them below 70. So always remember your HDLs, you want them high, your LDLs, you want them low. So that's how I help remember the difference between the two of them. Yes?
How quickly can you see the troponin?
Pardon me?
How quickly can you see troponin?
Like within an hour?
Within an hour?
Yeah. We'll test troponins like 3 hours, 6 hours, and 9 hours. We used to do them every 6 hours, but now we're recognizing them earlier. So we'll see if someone comes in, and I shouldn't say this because it is what it is. So if someone comes in on a Saturday or Sunday, and they're having chest pain, but they don't have the ST elevation, but they have elevated troponin, the doctors will put them on a heparin drip and then do the cardiac cath on Monday. Which is bad to say, but it's true. Just because the heart is not totally damaged all the way, I do have a picture coming up. But they'll monitor those troponins until, but if they get so elevated, or maybe if they stable off, if they keep increasing, maybe they'll do a cardiac cath. But if they stay the same, then they'll kind of let it go until. But it's true, they do that. Yes.
That's based on like how high it is, though, right? Like if it's extremely high.
It depends on their history. If they have CHF, they might have chronically high troponins anyways. So.
We had someone come in the other day with a troponin.
17,000.
That's the highest I've ever seen.
That's the highest I've ever seen. Yeah. Holy cow, that's pretty high. That's
They
like
came in.
cardiogenic shock. Walked in, drove in.
Family brought them in. No, I meant the CAT team came in.
Yeah. Huh. So no, your lipids are high. Why we want the highs? HDLs, because those are mainly proteins. There's only a small amount of cholesterol, where the LDL is all cholesterol. Those are bad for our heart. those are just bad. When we're doing cholesterol tests, if you have a patient, you want to keep them NPO the night before, so midnight, keep them NPO because then in the morning they'll get their labs drawn. If you work in a hospital or a patient office, doctor's office, educating them on how to take those lipid level tests, cholesterol tests. But now, I think you could just tell the lab that you ate beforehand. You just tell them, and I don't know, to be honest, I don't know how that affects your cholesterol. But NPO for 12 hours prior to. Other cardiac studies, we're looking at PT, your INR, we're going to look at those coagulations. Red blood cells, hemoglobin, hematocrit, white blood cells, and platelets, your ABGs, and all those electrolytes that are all going to rear their roaring head again. You'll always have to remember the normal for those. So, procedures, the first one is an x-ray. We want to look at the heart. We can see if the heart is enlarged. We can see if that heart is in the right location. ECG, we talked a little bit about this starting in campus lab. We're going to look at those rhythm strips. Do they look normal? Do they have an abnormal rhythm? Electrophysiological studies is something that's more advanced. Someone has had multiple lethal dysrhythmias. Maybe they go into VTAC, VFib. They gotta know why that is happening. So we'll do a more advanced test, which is an electrophysiological study. So someone that might have survived cardiac arrest, or like I said, any kind of tachy dysrhythmia. When we're talking about a stress test, well, we'll start echocardiogram. An echocardiogram is literally an ultrasound of the heart. We're just looking at the valves, and that's done in the bed, and it's non-invasive. They can just look at the valves. If you guys get a chance to look at an echocardiogram, it's pretty cool, because you can see the leaflets going in and out. You can see them moving. You can see any kind of, if they have cardiac tamponade, you can see the fluid around the ventricles or around the heart. It is pretty interesting to see. And then then we get into the stress test. There's two types of stress tests. There's a treadmill one, and then there's an adenosine one. The treadmill one, the person gets on the treadmill, they start walking, they start running, and they have wires on to make sure that the technician is looking at their heart rhythm while they are doing this. And what we're doing is we're putting stress on the heart to see what the heart does during the stress. Is it going to flip into a different rhythm when it's under stress? Is it going to stay the same and maybe a sinus tap? The other one is pharmacological one. Maybe the patient is 92 years old, they're not jumping on a treadmill, so they're going to do the stress test, the chemical one. So the biggest one with that is usually I tell them that they're going to feel like they're going to pee, but they really don't. But you do need informed consent, keep them NPO, take off any kind of nicotine patches or any kind of other patches, no caffeine before the test. During the test, and this goes for both of them, the exercise one and the adenosine one. Adenosine is the one that we usually give because it will stress the heart. It will actually stop the heart. And have them report any chest pain, shortness, breath, or dizziness. Inform them about that.
So do they just like sit down while they're doing it?
They do it. I don't know if they do it in the cath lab. I don't think they do it in the cath lab. I think they do it downstairs. I know they don't do it in the cath lab. But they're laying in a bed. They're not in a chair. They're laying in a bed. They got all the electrodes on. There's the radiology nurses there to report or to just make sure the patient's safe. And they just stress the heart. Stress the heart. What is the heart going to do when it's stressed? Get it stress test. And then if you pass the stress test, you don't have to have a cardiac cath. But if you fail the heart, I'm getting ahead of myself. Other things interventions are the arterial line. I think we talked some about this last week. That's where you have an arterial line, the fluids. This is what that pressure bag looks like. I don't know if I had this last week. I don't remember. But an arterial line is a line that goes in the artery. Can we talk about this? I won't waste time. We did.
He was in
We did?
17, I think.
Yeah.
The first
Well,
week we were there.
I know I talked to you guys about it.
No, we did it.
No, we didn't.
All right. Anyway, so the biggest thing is this is not to give medications or fluids. It's for blood testing and it's for just pressures within the heart and in the lungs. So for the arterial line and pulmonary artery catheters. Make sure they're secure because they're in an artery. So we gotta make sure those are secure, they're not bleeding, and strict infection control. I'm not gonna go too much into it because I think I do remember talking about this now. We keep the level transducer. If someone has one at clinical, while you're at clinical, go back into the ICU. Well, get your instructor to go back into the ICU. Mrs. Langenkamp will get you back there to look at one if hopefully someone's got one. But when we're talking about the blood pressure, some diseases, you were looking at on inspiration, the blood pressure lowers by 20 systolically or 10 systolically, and then raises after with exhalation. With an arterial line, the blood pressure is changing like every second, so you can capture that. It's a little bit easier to capture that diagnosis with arterial lines and pulmonary artery catheters. All right, we're going to go into the conduction system. Like I said, this is the blood supply to the heart. We're looking at what the heart, how much blood the heart is getting. What is that electrical signals that the blood is getting, the heart is getting. In EKG, they have all these leads. This is a 12-lead EKG. So all these leads are on the patient, and what these leads are doing, they're all looking at the heart. I've had this question a lot where you have on a strip, you have a top line with a rhythm and a bottom line with a rhythm, and they look a little different. And all it is each lead is looking at a heart in a different direction. So this bottom lead, maybe this left lower lead, maybe the QRS is down because it's looking at the heart from a different location. Where this AVR lead might be this, it looked like this. So when those leads look different, or the strip looks different, but it's the same patient at the same time frame, it's those leads are just looking at the heart in a different area. Someone trying to get in here? Is there someone trying to get in here? Lock the doors.
Active shooter. One-eyed fight.
And this is what you guys see at the hospital, is the 5 leads on the chest. And like I said, each lead is looking at the heart a different way. You can change which lead is to look at. You can change the size of the print. You can change a lot of different things on the telemetry. This is probably a review because I think you guys do this in last semester. The sinus node is our lead. This is the one that sets our heart rate. As you go down the electrical system, it gets lower. So the SA node is usually at 60 to 100. That's normal, right? But maybe the AV node is starting that heartbeat or contraction. And then if that happens, usually the heart rate lowers. And as you go down through the electrical system, your heart rate is lower than the SA node. So if the Purkinje fibers are the ones that are initiating the contraction, then your heart rate it's probably in the 20s to 30s, I think it is, for Purkinje fibers. Oh, 35 to 40. So, but this is how the the doctors can tell, depending on the heart rate and your rhythm, where the problem is within the heart. Like if your heart rate's in the 40s to 50s and you don't see a P wave, then they know that this SA node is not generating the electrical conduction. It's coming from the AV node. And this is just another look at that. So a rhythm analysis you've already done. We did in campus lab, so I'm gonna go over medications. And this is how I organize the medications because this is the way my brain works. I think it's easier this way, but if you guys know your medications a different way, then stick to that. But I put them in categories, okay? What medications or things increase the heart rate? Atropine, that increases the heart rate. Epi should be on there, but it's not. I don't know why it's not on there. Doesn't matter, but that could increase your heart rate. Anxiety increases your heart rate. Fear, exercise, right? All those increase our heart rate. What decreases our heart rate is adenosine, cardioversion, defibrillation. Usually that will, if you're in VTAC, pulseless VTAC or VFib, that will stop that fast, irregular rhythm and then slow it down, hopefully going into sinus rhythm. Beta blockers will decrease your heart rate because it's a blocker, right? It's going to block that stimulus, slows your heart rate. Digoxin, that does slow your heart rate, and then the vagal maneuvers. That's putting pressure on the heart. We saw this yesterday. The patient's heart rate was what, 160 something? 238. And then the nurse just had the patient breathe and kind of hold their breath, right? Bear down. And it came right back down to sinus rhythm. Doesn't always happen that way. Sometimes it happens for a little bit and then goes back up, but I was surprised she didn't go back up. But vagal maneuvers, you're bearing down. You tell the patient that pretend like you're having a bowel movement and bear down to have a bowel movement. Older people don't like to do that just because they feel like they are going to have a bowel movement. You can have them cough. I give them a straw, but I occlude the end of the straw, put my finger over it and have it blow through a straw. I've done that. But yeah, coughing, hold their breath, stuff like that. Puts pressure on the heart and it can slow the heart rate down. You might do this initially while you're getting like the crash cart or something like that if it's sustained. So those are things that decrease the heart rate. Meds that decrease your preload. So this is making less blood going into that right atrium, correct? We're decreasing our preload. So our diuretics, because there's less fluid going into the heart, right? Because we're peeing it all out. So there's less fluids getting to that heart. Our ACE inhibitors, why is that? What does that do? I know you're all writing it all down. So our ACE inhibitors, they are vasodilators. So they make that vessel a little bit bigger so there's more blood throughout the body. That also in turn decreases your afterload because now it's loosening that wrench. Okay, so that's why ACE inhibitors are in both columns. Nitrates, we kind of talked about. I'm going to skip over the phosphodiuresis. But nitrates, vasodilators, those dilate the vessel. That's why we have decreased preload. And they'll also be on decreased afterload also. I see the nitroprusside, but I see vasodilators on there? Oh, I do at the end. Why would a low salt diet decrease your preload? Less, yeah, the water follows the sodium. So if you have less sodium, that means that it's not going to be in the vascular system. So that's why cardiac patients are in a low salt diet, because we want to decrease that preload. We don't want to put more work on that heart. So decrease afterload, I kind of went over those also. wrench. So those are loosening that wrench. They're making it vasodilate a little bit more. That's why it decreases the afterload. Treating dysrhythmias. So now we're in AFib, A-flutter, VTAC, VFib. We're in a rhythm. So we want to stop that rhythm. And when we stop that rhythm, we're blocking something, right? So that's why our sodium, calcium, and potassium channel blockers are in there. Cardioversion and defibrillation can be in there too. But when we want to stop a rhythm, we can give a blocker because it blocks it. But you will need to know like the different medications under each blocker. Sodium is procainamide, lidocaine, or flecainamide. Calcium channel blockers are very nice drugs. So you've got verapamil, nifedipine, and cardizem. Most of them, what you'll see is cardizem. I'm surprised we haven't had that yet. But we give that for a lot of patients that are in AFib with a fast heart rate above 120. We give cardizem because we want to block it and slow it down. So we're going to give cardizem. We talked about doing a bolus ahead of time. A bolus is that, how do you define a bolus, except for that last group back there? What is a bolus? Large amount. It's not a fast amount. It's just like a loading dose. So we're giving, it's not because it's going at 999. It's just a loading dose, and it's used. So we can give a cardizem bolus, a dopamine bolus, or whatever. We can give those boluses, but it's usually followed with a drip. Increases contractility. That's giving our heart an extra little squeeze. So those are our positive inotropics, our digoxins, dobutamine, dopamine, norepinephrine, and all that. So those will increase contractility. So on the flip side, do those increase or decrease your preload? Yeah, that increases because we want more to get to that, especially with epinephrine, because we need to get more blood to that heart to keep the perfusion. So I would put your categories of meds like this. So when it gets to heart blocks, we want to I put those all in one category. You're going to recognize it as a Brady rhythm because it's usually a heart block is a low rhythm. So if anything, we want to increase that rhythm. We don't want to block a Brady rhythm. Okay, so we wouldn't give any of those blockers, channel blockers. And you do not need to know this part, but this is a sodium, potassium, and beta blockers, calcium. They all work at different areas of the heart, and that's what this is showing. Just to slow things down or to block that rhythm. It's just kind of a nice to know thing. Other medications that you'll need to know is digoxin. That is given for heart failure, or it could be used for atrial fib or atrial flutter. It is a positive inotropic because we want to give that heart an extra squeeze. But what's important to know about this, and I've been meaning to talk to somebody, and I don't remember who it is, but we need to listen to that apical heart rate for 1 minute before you give it. Apical heart rate's down lower. So we are listening. We're not looking at the telly and going, oh, they're 80. Let's go ahead and give it. We have to listen to it, and for 1 full minute. And if it's below 60, we are not going to give it. So we're listening to it for 60 seconds, and we're going to not give it if it's below 60, because it does have decreases the heart rate. Atropine, we use for bradycardia, that was on the list. So we're going to increase that heart rate. So your heart blocks, your bradycardia, we're giving atropine. The other one that I want to point out is adenosine. The adenosine we give for SVT. And the reason I remember the atropine versus adenosine is adenosine is for SVT and it has an S in it. And so does SVT. Atropine does not have an S in it, so we don't give it for
else for disasters? AFib, flutter, and what?
Heart failure, just heart failure people. But adenosine, so we give it for SVT, that fast heart rate, right? We want to slow it down. Atropine, they're a slow rhythm, we want to bring it up. So a lot of students get confused between the two of them because they see the A and they think, oh, that's the one it, but make sure you know which one is which. Other considerations, we have anticoagulants when people are cardiac patients. So Coumadin, warfarin, we want to make sure they don't change their vitamin K consumption because it interferes with Coumadin. Heparin, we are looking at their INR. We don't want them to coagulate so much. We want to decrease their coagulation because maybe they're at risk for blood clots. So they're on a heparin drip or just given heparin sub-Q. Most of you have probably given heparin sub-Q 3 times a day. We're monitoring their PTT and INR. We're making sure that, I gotta go over this now that I think about it. So, and we're just making sure their lab work is done correctly. So, have you heard of the 10-finger rule for your PTT and PT?
No.
I want to tell you guys this. So when you're monitoring heparin, HEPARIN, what's left? 3 of them, right? PTT. Coumadin or warfarin, WARFARIN, what's left is 2 more fingers, PT. So if you're ever wondering, oh, which lab result do I look for with each medication, use your 10 fingers. Okay? Fibrinolytics, this is given, I'm starting to see more of this given for our cardiac patients. This goes in and dissolves the clot right away. We mainly look at stroke. Yes, Steve.
I see the goal for INR is to
Oh, the goal, so that's more for PE. I stole this from my PE lecture. So when someone has a PE, we want your INR to be therapeutic. So decreased clotting would be 2 to 3. Your INR would be 2 to 3. What's our normal INR?
0.9 to 1.
Yeah, that's for you and I. But if I'm clotting a lot, like my blood is clotting, I'm going to be taking Coumadin or heparin frequently to get my INR to work from 2 to 3, because then it won't be clotting as much. And we just had this happen. What was the whole situation? It was in PCU, and I'm wondering if she was working. I'll think of it. But it had to do with that. Oh, I think there was a stroke alert. That's what it was. There was a stroke alert, and they were discussing whether to start, was this a patient candidate for fibrinolytic? If they're already on an anticoagulant, they're not a candidate for a fibrinolytic, but we were looking at the INR. Her INR was 2 to 3, so we're like, okay, she's probably not an ischemic stroke because she's adequately managed with the INR. So bleeding precautions. Coffee ground emesis, never normal. We're going to report that to the doctor, right? They're bleeding internally in their GI. Occult stool, occult blood, right? Dark tarry stools. Is that clinical? We have this?
Black and tarry stools.
Black and tarry stools. We're the only ones that use that phrase. So if you have a patient that says, I have black tarry stools, either they have somebody in the family that is medically trained, because I don't know anybody that calls it that, but us and doctors. So, but that's what we had in clinical. The patient kept on saying he had black tarry stools, and they went up and did a colonoscopy, and there was nothing. It was fine. So who knows? But black tarry stools mean there's bleeding in the stool, so that's not normal. Abdominal girth, we're measuring abdominal girth. Is there bleeding going on within the stomach that we got to monitor for? Look at your lab values and prevent injury. So when anyone's on any kind of anticoagulants, we're going to be monitoring for this, for any of those. And here's Randy. Randy's my friend, so we wanna make sure that we take care of Randy while he's on anticoagulants. So making sure we use an electric razor, we're not gonna use a sharp end razor, oh my god. No needle sticks, no Foley, so we're not gonna start a Foley or an NG when someone's on anticoagulants, because it's highly vascular, we can cause further bleeding. We wanna prevent injury, so we're gonna look for nosebleeds, bleeding of the gums. We're looking in the toilet, do they have black tarry stools, or they have blood in their urine? Do they have petechiae, do they have bruising everywhere? We wanna protect them, so we'll use lift sheets, but now we got the what is it called? Hercules beds, you just press a button, even better. So that's Randy, so we're gonna protect the patient. We don't wanna cause further injury. So sinus Brady, so when someone has sinus Brady, you do have another dysrhythmia test, so if you guys have any problems with any of these rhythms, let me know. They're not gonna be anything new than you've already given, but we're gonna go over treatments. So this heart rate is below 60, right? So we want to increase this heart rate somehow. The meds, what med do we give for, is it on there? No. Atropine. So what else, say we give atropine and it's not working, but this guy's blood pressure's in the toilet, it's like 60 over 40. We gotta get cardiac output, we gotta increase this heart rate. Pacemaker. So temporary pacemaker, do I have that in my back pocket? Where can I find that? All of our crash carts have temporary pacemakers on it. So you wanna get them on a temporary pacemaker, get that blood rate up. Epi, dopamine, IV fluids, oxygen can all help with bradycardia. And that's what I mean with, same with the blocks. Treatment is the same. It's treated as a Brady rhythm, because you'll have strips on the unit test and you'll have to tell us what you're gonna do about it. So treat your AV blocks, because it's a Brady rhythm, treat it as a like atropine, you can do atropine, you can do pacemaking, temporary pacemakers, same thing. Move them together. Are we good on how to read AV blocks? The biggest problem, it took me years after I was a nurse to finally get it sunk in my brain. Measure your PR interval. That's the key to your blocks. You're going through, oh, I got a P wave, QRS, P wave, QRS, P wave, QRS. I got that all the way through, right? Then you're like, oh, that's sinus rhythm, but then you measure that PR interval, and it's your first degree heart block. So the next one to the top right, you're seeing PQRS, PQRS, PQRS. Uh-oh, something's missing here. Measure that PR interval. See how it's short, it gets longer and longer, and then it's blocked. So we got Linky Bop. So over here, I got PQRS, 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 something's missing. After I see that first QRS that's missing, I think blocked. It's being blocked. That QRS is missing. So then I measure that PR interval. See how they're the same? The ones that I do have, they're the same. So that's second degree type 2. Did I say row?
No.
Oh, yeah, they're sayings, but
But it's kind of
it's not inappropriate for me to say. So here we got PQRS. Right there, P. There's a QRS. P, there's one missing, PQRS. Go measure that PR interval. It's all over the place. It's medium, large, and really small. There's no rhythm, so you know it's third degree heart block. So that PR interval is key on how you figure out which block it is. So you'll need to know that for next week. Unit test, if you recognize it's block rhythm, you'll be good. You don't have to say, oh, this is like second degree type what, this is what I'm gonna do. I just want you to know what you're gonna do for that. Next week is just recognizing the rhythms like you did the.
And the unit test B is the next week.
Next week is just recognize your rhythms.
She's scared of everybody.
Unit
Like, what?
test, you gotta tell me what you're gonna do for the rhythm.
Yeah.
So there's our rhythms, oxygen,
Wait a
drug
minute.
therapy,
The test.
acetylene, pacing again, permanent pacemaker, temporary pacemaker.
Have you found Quizlet for
Pacemakers, so here's
the ATI that's too
a
frightening?
pace, well, here's a rhythm, you
I
can
think
see the
so.
spikes.
Will you send
So
it to
then
me?
what kind of pace is
Yeah.
this?
Thanks.
Ventricular
something.
pace, because it's right before the QRS. So pacemakers are battery operated. They insert it into the chest. You can usually see it in somebody's chest. They're battery operated. They usually last 10 years, 10, 15 years nowadays. But there's two types of demands or two types of settings on the pacemaker. Synchronous, which is demand pacing, or asynchronous, which is a sync rate. So these pacemakers, if it's a demand pacing, if your heart is doing what it should, and then there's a pause, your pacemaker is going to go, oh, we're not doing what we should, so we'll throw a shock for you to have a contraction. So that's an on-demand pacemaker. If it's a fixed rate, they can set that pacemaker at like 60 beats per minute, and that's what that pacer is going to do.
Now, will it speed up? It's like,
It won't speed up.
it'll just stay.
It stays at 60. But can the heart rate speed up on its own? Yes, and then maybe you don't see any pacer spikes. But I feel like recently we had one. But you will, so it could be on demand. The only time they have a pacemaker is if they're in a block or something like that. They have some type of heart block. So they're going to get a pacemaker in to set that pace. When they test, it's kind of cool to watch. Not cool. It's kind of cool. It is cool. When you see the intrinsic pacemaker of the heart, that means a patient's own pacemaker, is they do this in ICU settings. They can turn the rate down on the pacemaker and see what that heart is actually doing. You'll see the heart rate slow down and see like if the heart rate's at whatever it is, 30, 40 rates per minute. Here is a Brady rhythm. I can't remember, it's been a while. But this, you can see this is a Brady rhythm, and then afterwards we got the AB.
Spike.
I wrote up the name, I wasn't here because it was on there. But you can see this one's AB paced, and you can see the atrial pacemaker is not firing all the time, but the ventricle is. That means the atria is sometimes doing its own job, but the ventricles are not responding. So that's why that ventricle is fired each time, because the atria is like, hey, you're supposed to follow me, but then if the ventricles don't, then the pacemaker kicks in. So this is what it looks like. They come back after its insertion, and the wires, that's what these are right here. I was gonna walk back here. But this is what the wires are. These are connected to the heart. It gets fed through this catheter, and that is what's connected to the heart. You can see at the end of here, there's just kind of like two channels that go into this. So it's plugged into this, and this is how we can set the rate and the milliamps of what we call. So this pacemaker is set at 80, so we can turn this dial. We can turn it down, we can turn it up, depending on what the patient needs. The milliamps, the output for the atria and the ventricle, is only at 10. So they only needed like 10 milliamps for the atria to respond, and 10 for the ventricles. If you're sitting there, well, not you, the doctor, because usually this is done when it's first inserted. But if the heart rate is not, you're not seeing a spike or capture, you're seeing a spike, but you don't see the atria or a P wave, they might turn that up to maybe 15. They'll keep turning up until they see a P wave after the atria. And the same thing for the ventricles. Maybe they have it at 10, but the ventricles are not kicking in. So they can turn that up until they start seeing the ventricles kick in. And that's how we do it on the crash cart too. Get it? Got it? All right, sinus tach. This is going too fast. We need to slow things down. So the heart rate's above 100. So if you go too long in a tachycardia rhythm, your heart's going to give out. So we need to slow them down. So any kind of blocker medications would work because they block the stimulus. So a blocker would work, but check the blood pressure before you give it. Treat the underlying cause. Vagal maneuver, we talked about that. Digoxin, adenosine. But treat the underlying cause. But in cardiac with sinus tach, initially you might have increased cardiac output, but eventually the heart is starting to give out and then things start to lower. PACs, here you should have PQRS, and T-wave, but it is above 120. PACs, this is the hardest one, I think, for some people to see. But if you're going through and you see PQRS, and you're like, shoot, what's that? I don't know what that is, but I'm going to ignore it for now. And keep going through and seeing PQRS, and then here you are again, it's the same thing. Then most likely it's a PAC. And a hallmark thing occurrence after a PAC is there's a long a long interval between the Q and the T's. Or not the Q's and the T's. The T's and the T's. The QRS's. So that's a hallmark sign after a PAC. Is you'll see something, look afterwards, because that T wave is probably hidden in here somewhere. But there's a longer pause after each PAC. That's kind of a hallmark thing. That is just treat the underlying condition. If it's like still within 60 to 100, we're not too concerned about it. Maybe they drink all those Red Bulls, or they drink a lot of caffeine or something like that. So it's just really information. Infection, anxiety. AFib, I think most of you are okay with this. So AFib, we have that squiggly line, and then you see a QRS. This is not a good one because some people might look at that, that looks like a letter, but it's really a squiggly line. So what's, again, a blocker would work. So we got our calcium, potassium channel blockers, beta blockers. What's the other risk factor with the squiggly line like that? What? A clot. With AFib, our atria is just quivering. So clots can form. So we want to put them on an anticoagulant, whatever it is. Coumadin, probably not Coumadin, heparin, Plavix, trying to think, aspirin, aspirin, heparin, Lovenox, all of those. Coumadin, all that. Those, Xarelto is a new one. Not new, it's been around for a while now. But, so with someone with AFib, we're worried about they're at increased risk of stroke because of that clot formation. So some patients that are having surgery have a history of AFib. What are you supposed to do before surgery? Stop your anticoagulants? Yes. So they're at high risk for having a stroke before their surgery or right after their surgery because of that. So we got to be really careful with patients that are on AFib or anticoagulants. Here's a patient that had an AFib with an RVR, what we call with an AFib with a heart rate above 100. So you're not going to have to know RVR, you just need to know like a fast heart rate AFib. One of the medications we give is Cardizem. So you can see they're in AFib, this looks pretty bad. And then they gave a bolus of AFib and then they go into sinus rhythm. It like slowed things down and the heart was able to keep up. What?
You said they gave a bolus of
Oh, QRSs. So we can give our things, antiarrhythmics, these are all the blockers, and then also anticoagulants because we don't want blood clots to form. A treatment, I skipped over other treatments for this, because I was so worried about the meds. So the treatment for AFib and A-flutter beyond medications are the same thing, is ablation. They can go in through it's like a cardiac cath, they go in and they ablate or cauterize the area that has the extra stimulus in the atria, because then it deadens that stimulus, so hopefully they'll go into another rhythm. It just creates a scar tissue. There's another procedure called the Bayes procedure where they can go in and actually put sutures in the extra cell that's being excited and throwing your heart rhythm, the atria, into a different rhythm. Yes,
How do they find that exact right spot?
they go in and they manipulate your heart.
Oh, by.
They go with the cardiac cath, the catheter, and they can go to that spot and they poke around.
Okay.
Yeah, they poke around, I know the doctors will, they'll go in, do whatever they have to do, and they poke around a little bit more to see if it changes, they can cauterize it, if they go into a sinus rhythm, great, and then they kind of poke around, see if there's anything else. Yeah, it is pretty interesting, the heart is kind of cool. Told you about the Bayes procedure, the ablation. PVCs, again, we're looking at ventricle rhythms. So this is a ventricle. A ventricle is coming extra. Again, our blockers, those are good things that we can give. But we want to eliminate the cause. So this is the one to the top left what kind of rhythm is that? Obviously it's PVC, but is it unifocal or multifocal? Unifocal, because they look the same. I can't call that anything. And the one to the right is multifocal. Those PVCs look different, right? Okay, know that. The other PVC type things that we have them bigeminy, trigeminy, and quadgeminy. I think quadgeminy is on the next page because there's a lot of different ones. But don't call it trigeminy or quadgeminy unless you have 3 PVCs. But treatment is the same. I'm going to go to this one first. So what if, now everyone look at the front. Because if you only have the strip from here to here, you can't call this quadgeminy because you only see 2 BPCs. Because after that, it could be all sinus rhythm, or in front of this could be all sinus rhythm. But if you see 3 PVCs, you're going to go, yeah, that's definitely quadgeminy. So make sure you see at least 3 PVCs before you call it that. But again, if there's an extra stimulus happening, a cell is getting excited in the ventricles, so it's firing early. What is it? Eliminate the cause, caffeine. Maybe it's potassium. Maybe the magnesium is low. Potassium is low or high, actually. Beta blockers, sodium channel blockers, those would all work. And know what medications. Beta blockers are easy because they have the OLL. But when you get into the sodium and the calcium channel blockers and the potassium channel blockers, it's a little different. The other one is SVT. So this is very typical of what SVT looks like. There's only one little hump between the QRSs. And it's that erratic stimulus in the heart. It's firing, one impulse is repeatedly firing, the heart rate's above 150. So they can't sustain this, so we need to stop it soon. So you can do vagal maneuvers, vagal stimulation, slow that down. The antiarrhythmia is adenosine because it's an SVT, it's got an S, so we can give adenosine. And then your beta blockers, calcium channel blockers, and all that. With this, you can do synchronized cardioversion. We only do cardioversion when the patient's alive. Like they are up, they're awake, and we can cardiovert them. We don't ever defibrillate them when they're alive. And I'll talk more about the difference between the two. You can do an ablation on this one also. But knowing the difference between cardioversion and defibrillation is important. VTAC. So this looks like tombstones. The first thing we do is check a pulse because there's two different pathways on how to take care of this patient. If they have a pulse, we're not going to defibrillate them because they're not dead. They're awake, they probably can talk, they have a pulse. So we can give oxygen, we can give medication, and we can do a cardioversion. We cardiovert pulse, VTAC with a pulse. Because we'll put that crash cart on them and we can have the crash cart capture when the T wave is happening, and then we're going to, or the QRS to cardiovert. If they do not have a pulse, that is when we defibrillate. So they don't have a pulse, they're dead, we defibrillate. So when you're doing plans of care, when you're test taking, make sure you know the difference between the two. So check, that's why the priority with VTAC is check a pulse first. EFib, there's no question about that. This person's dead, there's chaotic electrical activity in the ventricles. There's no contraction, so we're just gonna go and defibrillate. So we only defibrillate in VFib and pulseless VTAC. And do we want to give any blockers for this? But here's the difference between cardioversion and defibrillation. Cardioversion, there's some synchronized rhythm. It's not the best, probably, but there is a rhythm, and we want to cardiovert them. They're alive because we want to slow things down and hope that the SA node takes over again and get them back into sinus rhythm. In defibrillation, there's unsynchronized chaos in the heart. The patient's dead, there's no pulse, so that's when we defibrillate. Okay? And you will need to know the difference between the two. The other thing that happens is an ICD. So our pacemakers can be a pacemaker and a defibrillator. So some patients have a pacemaker, some patients have an ICD. It also has a defibrillator. That ICD is identifying the VTAC pulseless, or the VTAC or VFib, and if it recognizes that, it can shock the patient into a sinus rhythm. So if a pacemaker is just regular pacemaker, they're not going to shock the patient, but the ICD will shock the patient. I had it was a couple years ago, we had a student taking care of a patient, and the patient had an ICD, and I shouldn't laugh, but the family members, she kept falling asleep during dinner, and I'm like, oh, and you can put a little device over the pacemaker or the ICD to see what the history was of what's going on with that thing. Well, the pacemaker defibrillated a whole bunch of times. So the family's like, yeah, she kept on falling asleep. We're like, no, she was dead. She was dying, and then it would defibrillate her. She'd wake up all of a sudden. He's like, yeah, she'd wake up. And we're like, yeah, because she got defibrillated. they couldn't understand that. But it was that's what I said. Not funny, but it was funny. All right, asystole. There's no electrical conduction. There's no nothing. So are we going to defibrillate this?
No.
No.
No, because we can't do it. There's no electrical activity to stop. So what are we going to do? Check
We
pulse?
check the lead.
We check the lead.
Okay.
So we check the lead, because what if the lead is just hanging off? We're not going to go in and start doing compressions on a patient that's just sleeping. We just want to make sure their leads are all on, because there might be a lead that's off. So we check the leads first to make sure that they're all on. And then after that, then if all the leads are on, they're definitely dead, we do compressions. We go to CPR. Okay, check the lead and asystole. But these rhythms, you will need to know what to do for these rhythms. Some of them are select all and apply. You have to
Oh,
increase
God.
them more than last test.
She's
So
just
whatever
saying
last
for
test is,
this
you're gonna increase.
quiz coming up, we'll identify we'll identify the rhythm, and then we have to say what did you do
That's what we're
for that
getting
rhythm.
to.
Any
All right,
test?
so what's
Any
the
test
for the quiz next
pathophysiology of a dysrhythmia?
Okay.
What would you see on the test for if it was worded? If there's no picture of a strip? Yep. Okay. Because there will be pictures of strips on the test. I gotta make sure that they're visible. Check strips. Now let's have that. What's left? They're like, there is nothing there. Okay, so electrical. Okay, how else? What's another one? What did you say? I didn't kind of listen. You just said electrical chaos or something. But how do I know that's not the right one? Well, how can I figure out what dysrhythmia that is by just saying that?
Like, what do you mean? Like, how to read them?
Not how to read them. Like, how can I say it in words? Like, how can I say VTAC in words? Well, that's not it, because you could just say, I have a patient that's in VTAC. What are you gonna do? But what can I say for bradycardia? Yeah, heart rate less than 60. You have a patient, you don't have a strep, but you have a patient, heart rate less than 60, but it's sinus. It's not a block, so what are you gonna do? Atropine, temporary pacemaker. So decrease, so they'll have decreased cardiac output, decreased ventricle filling, clot formation. When there's clot formation, we're thinking AFib, aflutter, stuff like that. Electrical chaos in the ventricles, that's AFib. Does that sound right? What is, go ahead. Decrease the vascular change. They're all gonna have, decreased cardiac output because the ventricles are not filling, or the atrials are not filling correctly, adequately. Adequately is a good NCLEX word. I did a quiz at the end of class one time, so I gave a strip, and I'm like, just give me a treatment. Someone put oxygen for all of them, and I'm like, oh, you're kind of right. That's an easy one. All right, so ventricle dysrhythmia. What assessment findings do you think you'll have? The patient will have heart palpitations, shortness of breath, anything that we talked about, decreased perfusion, right? Syncope, weakness, fatigue, maybe a low blood pressure, palpitations, cool, clammy skin. So someone with a dysrhythmia has lack of perfusion, so that's why they're going to feel all these things. So what are our medical interventions? What? Oxygen. Besides oxygen. That might be on there, but that would be part of the select all of the flags. What? Cardiac monitor? But they're probably on it if we know that they have a dysrhythmia. prone, blow through, and included straw. Those are all vagal maneuvers. But your medical medications, your blocker medications, and I think first one, anticoagulants.
What about in TV shows when they like?
Some that's against the law now.
Really?
Yeah, you're not supposed to do that, but you'll see some
What do they do
older,
that for?
just like Martha, yeah, I know, Martha, yeah,
All of it.
yeah, he well.
I mean, what rhythm would you be in?
VTAC or VFib. Yeah, and you can see it on the monitor. You'll see like a chaotic rhythm, and then you just see like what looks like a big PVC. And what's they call it? It's called a pericardial thump. That's not within our plan of care anymore.
Wouldn't that be like non-invasive though? Like in a way, I've never. Versus shocking them. Battery. I think I'd rather get punched than
No,
electrocuted.
well, you're dead, so it really doesn't matter. Usually you're dead. Now, because that's not gonna change the electrical rhythm. We want the electrical, I mean, yes, it's fast, it's boom, but we wanna change that electrical rhythm. But yeah, pericardial pump used to be in the plan of care. When I went through school, it was not in the plan of care anymore, so that was 2007 when I graduated. So it's been out, but I have seen people do it. I have seen people do it, and it doesn't work.
It does not
work, not all the time.
Have you seen it work?
No, he's fired now, this one guy that used to work in, he's not fired because of that, but he was fired because he was buying stuff online during work. I don't know who this person is.
Lord have mercy.
But he would do it.
We have a doc that, when we get a patient, like, comes in with SVT, they give them like a syringe, they have them go on the back while they're sitting straight up, and
Yeah.
then they put the head back and put their legs in the air. And I've seen it work, but it looks very awkward.
It's awkward, but blowing through the syringe, I know that, I think Hannah said that yesterday, you give them a catheter and blow through it, like blowing through a straw. It's creating the Valsalva maneuver and throwing the head back. Where's all the blood going to when you throw the head back and the legs up? Right to the heart. So it's putting stress on the heart, hoping to stop it. Yeah, it just depends on practices. A lot of times there was a strip yesterday. We didn't know if it was sinus tach or SVT. I don't know. Someone showed me a strip. But sometimes the doctor will do a carotid massage. This is another thing that nurses cannot do. Is they'll massage the carotids, and I should only do one at the time. But that slows down the rhythm to see if it's sinus tach or SVT. They can slow it down. And what the doctor does, especially in the ED, where I've been sent out to the monitor and then just watch the monitor while he does that. And so then he just hit print while our old ED, you could just yell from the room, but now it's a little different. But yeah, so that's been done too. But yeah, no more pericardial pumps or the carotid massages for nursing. But that's old school, that kind of stuff. Not carotid massage. But all it's doing is really kind of, the carotid massage is a Valsalva maneuver or vagal maneuver, and the thumb is just hitting that heart, hoping that something happens. All right, a patient, let's see, is 75, is AFib, admitted with dizziness, palpitation, heart rate is 150 with narrow QRSs. Which dysrhythmia is, I didn't even know I had this here, is most likely to this patient in? What is the treatment priority? So we know they're in
I'll go with
AFib
C.
with heart
Yeah,
rate
C.
150, above 150 is SVT.
That's
So they're in
supraventricular
SVT, we're gonna
tachycardia.
give them C. Did, sinus tach, are we gonna defibrillate?
No.
Atrial flutter, are we gonna give atropine? Probably not, because there's a lot of things we don't want to do to the what is the main mechanism of the action of digoxin in this scenario? And you're like, oh my God, I don't know. She didn't talk that much about digoxin. She just told me AFib, flutter, and heart failure, right? But what does digoxin do? Slows things down. So then you just go through and go, well, it doesn't increase, so I can throw A and B out, right?
No, I think it's B.
Does it reduce atrial contractility? Or does it slow the SA node conduction? B.
C.
If it slows the rate down, what's happening to the conduction of the heart? It's C. It slows the SA node conduction. Because the atrial is not gonna go off unless it has an electrical activity. And so that's why we look at that SA node. We wanna slow that down, and that begins our contractility. So when you're deciphering how to answer questions, go through each one and try to eliminate. Alright, so this one has COPD, is this the one that I was supposed to, the monitor shows this. Which type of heart block is this, and what is the immediate, what interventions are indicated? So is it sinus Brady? But it's got only 5 beats. Why is it not sinus Brady? What's missing? So after that fourth P wave, there's a missing QRS, so we automatically go to a block. And why? So we're eliminating A right away. Second degree, but which type? One, because it's winky bot, right? It gets longer, dropped. Well, then that tells you your answer right there. After P. Well, that one you have to read. What about this one? And this is typical. I probably, on the test, I won't ask you to name the rhythm. I'll just say, what are you gonna do for this? So this is what? No, what rhythm is it? Oh, right there. B. Yep. Alright. But yeah, on the test, I won't ask you what the rhythm is. I'll just say, what are you gonna do for this rhythm? On the unit test. Next week, it's gonna be, what is this rhythm? Like the last time.
How many do we have?
On the test?
Okay.
Next week, 15, like the first test.
So just identify for the quiz.
Next week's quiz is 15 questions, just like what you did a couple weeks ago, 3
Okay.
weeks ago. On the unit test, I don't know, I can't remember. I don't know. There's a few, handful. Obviously, am I gonna put sinus rhythm up there? I'm gonna do your kind of bigger heart blocks, more invasive heart blocks, I guess, or heart rhythms. So, yeah, so just know the treatment. Yes.
Wait, the treatment for next week's quiz?
No, next week's quiz is just your heart rhythms like you did
Just
3
like,
weeks ago.
okay, just
On the
identify.
unit test, it's gonna be treatments.
Okay.
But I won't put, like, is this gonna be trigemini with this blocker? I'm gonna just take off the identifiers of the rhythm and just say, which one are you gonna get,
Okay.
okay?
Okay.
Treatments, you'll need to know the treatments. Alright, how far? Alright, let's do this intro to cardiac and then after. Well, I guess we're gonna do cardiac. So what are our risk factors for cardiac problems? Smoking, age, family history, obesity, diabetes, controlled diabetes or uncontrolled diabetes? Uncontrolled, read the everything. Stress, surgery, family, increased lipids. So if you're getting a test question that, usually these are good select all replies. Like, and we're not gonna say, okay, they have increased lipids. I'm gonna say they have, what am I gonna say? They have triglycerides of 200. You'll say, "Oops, that's one. That's not good." So you'll pick that one. So that's why knowing your values will be important. Coronary arteriosclerosis. So this is where the plaque is starting to build up in your heart vessels. This is the coronary system, which is going to the heart. It's not throughout the body, it's just the heart. We're looking at the blood flow to the heart on this. So cardiovascular disease is when plaque starts to build up in those vessels. And you can see the one to the left looks nice and clear and beautiful. But as we age, the one plaque starts to build up, and depending on your lifestyle, you can have more than others. But when plaque starts to build up, it's starting to tear apart this wall. It's starting to degrade the wall of the arterial system or coronary system. An MI occurs when there's so much buildup that now blood supply is being blocked to the heart. And that's when they start having chest pain. So when someone has chest pain, they're starting to have increased lipids or increased plaque in their heart. We want them to educate them on controlling their cholesterol, exercise, diet, manage their diabetes, manage their blood pressure, no smoking. So these shouldn't be a surprise for you, right? So I'm going to get through at least the main types of angina. So there's stable, unstable, and variant. You will need to know the difference between these. Stable is someone has chest pain, and then within 15 minutes of either rest, so say they're at school and they're stressed, but then they go outside the classroom and just sit for 15 minutes or pop a nitro, and the pain goes away within that 15 minutes. Unstable angina is when that pain lingers for more than 15 minutes, even with nitro. So you take your nitro and you still have pain after 15 minutes, or you go in and relax somewhere and the pain lasts for more than 15 minutes, chest pain. Variant angina is more for muscle spasms. You might have like a quick pain, but it goes away, and that's usually just a variant that your vessels are spasming, causing the chest pain. Okay? So you will need to know the difference between the stable and unstable and variant. So expecting finding when someone has chest pain, they're going to have pain, they're going to have apprehension, feelings of that impending doom again. Usually with chest pain, it radiates. Males, it usually radiates to the left arm, left jaw, cause dizziness, numbness, weakness. But there's some kind of pain, radiating pain going somewhere. Women, usually they feel back pain. Maybe they just don't feel comfortable. Usually women have subdue symptoms, whereas they might have back pain for a while, they just don't check it. I would tell you a story about myself, but I don't want to waste time. But tachycardia, heart is not getting the oxygen, so it's going to speed up because it's like the heart needs oxygen, right? So it's going to speed up. You're short of breath, or you're going to have tachypnea, diaphoresis, vomiting, maybe a decreased level of consciousness, pale, cool, clammy skin. Medical management is usually, goal is to decrease oxygen demand. That doesn't mean decrease oxygen. It means that we don't want to exert our body to exert any more oxygen. So we'll apply oxygen to the patient. We want to get more vasodilator, so it's going to vasodilate those vessels so more blood gets to the heart. If we vasodilate, so it can maybe get more blood around that plaque. It gets more blood to the heart. Beta blockers, because it decreases the oxygen consumption, it slows down the heart, hopefully to conserve some of that oxygen. And same thing with calcium channel blockers. It decreases the workload of the heart. meaning the heart is not working so hard anymore. And then anticoagulants, because we want to prevent any further clot formation. So this assessment is not new to you guys. Just where's your pain? Does it radiate? What's your pain scale? What's your pain scale? Does it hurt more when you exercise, or does it hurt? When does it aggravate it, and when is it better? So you're asking all those factors to the patient. Okay.